You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bedside to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, and today we are joined by Deborah Watkins Bruner, Senior Vice President of Research at Emory University and Professor in the School of Nursing and the Department of Radiation Oncology in Atlanta, Georgia, and a presenter at the 2020 ONS Bridge Virtual Congress to discuss social determinants of health, their impact on cancer care, and what oncology nurses should be aware of when providing care to all populations, no matter a patient's background. Thank you for joining me today, Deborah.
Thank you, Stephanie. Pleasure to be here.
To start us off, I'd like you to help us understand the definition of social determinants. What factors do they encompass?
Sure. The Oncology Nursing Society taps into Healthy People 2020 and their definition of social determinants of health, and that includes conditions in the environments in which people are born, live, learn, work, play, and worship. It also encompasses sociodemographics, age, race, education, and income. And it focuses on how these factors affect people's health, functioning, quality of life, and health outcomes and risks.
What are the negative effects of social determinants along all aspects of the cancer care continuum that you see?
Social determinants of health affect every aspect of a person's health. We are seeing that clearly today in the news. It's affecting the COVID outcomes, but it affects every outcome, including cancer outcomes. The reason is that when you are born into an environment that is less healthy in terms of an environment where you can get fresh fruits and vegetables, an environment where you can walk safely, an environment where you can get a quality education, into an environment where you are less worried about violence, including gun violence, less worried about drugs, an environment where you can get the medications that you need and afford them, it affects everything. So when people come into the hospital with a diagnosis of cancer, we have to understand the social determinants of health to understand their baseline health status. And social determinants of health help us understand that people that are living in poor neighborhoods with lower education and less access to healthy environments frequently come in with epigenetic changes and underlying comorbidities. These frequently include obesity, cardiovascular disease, cardiopulmonary disease, asthma, and diabetes. And with these risk factors, they put people at risk for absolutely every worst health outcome imaginable, from cancer to COVID.
You mentioned a few of the socioeconomic and geographic things that these patients come to us with. But as nurses treating these patients and caring for these patients, what are some of the things that we should be aware of regarding these patients' socioeconomic or geographic backgrounds that we could include in their assessments when they come in, and how we can start planning our care specifically for that group?
So these social determinants should be a standard part of our intake. And unfortunately, zip code matters. There is tremendous work done at major universities, including Harvard, through the work of Dr. David Williams, that shows that zip code is more likely to predict mortality than genetics or race. And so knowing and understanding where people live or have lived most of their life, where they've been born and what they've been exposed to in their environment, can help us plan referrals right from the start and immediate interventions. Knowing that people are predisposed to obesity and cardiovascular disease, even silent cardiovascular disease, it may be helpful that we get referrals from the start of cancer therapy that would help people undergo treatments and maintain their treatments. There are also other issues like economics. We don't pay a lot of attention to the economic status of people that come in unless they frankly tell us that they're unable to pay for their cancer treatment. But if someone is unable to pay for their cancer treatment, it also means they're likely to be unable to pay for the treatments for the comorbidities that need to be attended to while they're getting their cancer therapy. If they cannot afford cancer therapy and their diabetic medication, they are most certainly to have a worse outcome than those who have diabetes under control while they're being treated for cancer.
What good points. And, when we're thinking about that, maybe down the road, but we think about the financial toxicity that patients end up with. And, that's a big issue, but I can see where looking at the social determinants and, wondering when patients don't even come in because they think that they can't afford any of that and how much that's going to impact all of that outcome. So how have we improved addressing and navigating the social determinants, and what work do you think we still have to be done? I'm sure a lot, but what do you think are some areas?
Research has come far in documenting the impact of social determinants of health on health outcomes across the board, whether that's cardiovascular disease or oncology. We have far to go in terms of addressing and navigating the social determinants of health in research, clinical practice, and health policy. In fact, we've done a better job of documenting the social determinants than we have in addressing them. Most clinical trials do not include standard assessments of the social determinants of health that tell us nothing about the variation in outcomes based on social determinants. We know that this is an oversight and that if we had them, we would be able to really understand the impact much better, and that would help inform interventions in the future. That's just in research. In terms of clinical practice, in oncology practice, again, we do not in any standard, consistent way assess the social determinants of health. We have no care plans in a standard, systematic way that addresses the social determinants of health. And for all of that, the bigger elephant in the room is health policy.
What can you tell us, does the research tell us about social determinants? You talked a little bit about where your zip code and how zip code really matters, but what are some of the other areas that research is looking at social determinants?
We're looking at the epigenetics of the impact of social determinants. So we know that through institutionalized racism in the United States that started with slavery, and then the Jim Crow laws that literally put political red lines around areas where African Americans lived, that also determined their resources or lack thereof. So these red lines put people in segregated areas that gave them less access to green space, to nutritious foods, to safe areas for physical activity. It put them in areas where there's greater gun violence, greater pollution. These combined affect chronic inflammation and health and affect gene function at various stages of the life cycle. What we're also seeing is that those who are subjected to racism and discrimination have higher levels of inflammation throughout their life. That makes them susceptible to all those comorbidities we just discussed. Also makes them susceptible to higher levels of inflammation, which set them up for baseline higher levels of risk for cancer and risk for poor outcomes for cancer, both because of the genetic predisposition then, not based on race, but based on the social environment, and also because of less access to good care, less access to good education that makes people have higher health literacy and understand what they are to do to take care of themselves, and less access to standard treatments, good clinical trials, and to the drugs, even for cancer therapy. We've seen research show that, for instance, African American women sometimes have a lower risk of getting breast cancer, but once they get it, they have a 42% higher mortality from breast cancer. Part of this is due to delayed access for diagnosis, and also part of it is due to the fact that African American women often get less courses of chemotherapy compared to their white counterparts.
Those are some impressive numbers. And when we think about how the population is treated and offered care, I think those are really important things that we as nurses definitely need to start looking at and considering and working on that education to those communities that we are seeing those numbers and how we can definitely start making change in there. So as healthcare professionals, and the fact that we do advocate for our patients, what are some things that we can do to work to limit the social determinant barriers to care?
So clinical oncology nurses could work with professional organizations like the Oncology Nursing Society to create standard assessments that include the social determinants of health. They can work to have at-hand ready a list of resources for those that are subjected to poor social determinants of health or these poor environments. They can be ready with a list of referrals, and that would help tremendously. In terms of what researchers can do, they can also come together for standard assessments of social determinants of health. And together, clinical nurses, clinicians, and researchers can advocate with the state and federal government to address health policy that affects social determinants of health.
You were talking about the assessments, and it's interesting to me. It's almost like comparing, where the comfort level of talking and asking questions about a patient's sexuality or sexual, health and talking to them about that. It's almost like we're not talking about the social determinants either. And those things are so much, I don't want to say more important, but so important to the outcomes, like you're saying, of the treatments and the care that they're getting. And we need to be doing a better job at that. You talked about health policy and things that need to happen in that arena. So can you tell us, is there health policy work that is being done now to improve access to care?
There's constant conversations and legislation that is introduced into both state and federal governments, and yet the policies have not been, since the formation of this country, sufficient to address the severity of institutionalized racism. And in fact, some of the legislation with the Jim Crow laws institutionalized the worst of social determinants of health by institutionalizing segregation and social environments and social experiences that affect an entire population. While many states have made some inroads and federal legislation has helped somewhat, it has never gone far enough. And in fact, we see the very outcomes of this playing out on the news every day in this current environment. For instance, let's look at COVID for a moment, because it has similar poor outcomes as we see in cancer for those who have poor social determinants of health. And we saw that by policy, in the beginning of this, we were not even looking at race for who was dying of COVID. So we see this in oncology. We don't always report race in our outcomes. health policy must address and mandate that the social determinants of health be reported in every research study and in all quality metrics related to oncology clinical outcomes.
It is interesting that with everything that's going on with COVID, that it's bringing a lot of other things, to light and to be able to see and compare those issues. So when we're working with the patients and their caregivers, can they do anything to reduce their own barriers from social determinants or things that we can help them to see where they can reduce those barriers?
I think they need our advocacy most, but the patients and caregivers can also, where possible, advocate for themselves. But by the very nature of the social inequities, some of the patients we see do not have the health literacy that would make them capable of advocating for themselves. Some most certainly can, even in poor social environments, advocate for themselves. And when that's possible, making the point to say that they would need help in juggling the medications for their comorbidities as well as their cancer medications. To make the point of saying, when we tell them to exercise, that they don't have a safe place to exercise. So how can we help them? To making the point that they may have transportation problems to get to a good, appropriate oncology site to get their care. So feeling empowered that they can speak up and having the self-efficacy to believe they would get help would be some of the things that we would like to educate and transmit to those who suffer from poor social environments and poor social determinants. But again, that takes education on our part. And whether that's a handout or a conversation that says, speak up, here are things that we can help you with if you let us know. But that really would be rolled into the assessments that oncology clinicians would need to make, or researchers.
That is so important. And, while I think about my personal time in clinical practice and just from what I hear from ONS members and the amount of work that nurses are doing in the clinics and in the inpatient areas and just learning all of the new medications that are coming out so rapidly and being able to understand that, and then adding on to that, having those resources. And I think you're right, be able to have kind of standardized assessments that will help show where those areas are and help to point out what the needs are of those patient populations, but then also to be able to have resources for your area, because that's going to change from one city to the next or one rural area to the next, and how important it is to, make nurses aware of that and our colleagues in trying to look out for those types of things. What are some things about social determinants that often not discussed, but you wish people were more aware of?
There are several things. There was an excellent op-ed that came out in the New York Times on June 4th, and it talks about who is most likely to die from coronavirus. The prevalence of comorbidities among the top 10 income earners and the poorest or the lowest 10%. And it showed by city, big city, New York, Chicago, Kansas City, Los Angeles, Houston, Chicago, Phoenix, etc. It showed by income that chronic pulmonary disease, asthma, hypertension, diabetes, obesity, and kidney disease are almost vertical lines compared to the richest and the poorest. And again, we just do not routinely talk about it. It is not discussed as a standard way of talking about health outcomes and, for our particular purposes, cancer outcomes. So this standardized assessment, both in clinical practice and in research, is so critical and not discussed enough. But here is something that we also do not discuss, and you're going to have to pull me off with a cane because now I'm going to get on my soapbox. The National Cancer Institute funds tremendous work in cancer, obviously. Most of the work, and I don't have the percentage, but I'm going to guess that 90% of the studies that are funded by the National Cancer Institute do not ever include social determinants of health. And in point of fact, for cancer clinical trials, social determinants of health are second-class aims for most studies. In fact, the National Cancer Institute has just supported a major study looking at cancer outcomes by COVID risk and by COVID diagnosis. And when they opened the study, those of us who look at things like social determinants of health and patient-reported outcomes were distressed to see that none of that was included in these assessments. Now, as we've just tied COVID and cancer outcomes to the same social determinants of health, and that we see it every day on the news, the fact that the social determinants of health and patient-reported assessments were excluded from this study cannot be more distressing. Now, there is a move on to add these belated to the now already open and accruing study. And when social determinants of health are added to clinical trials, on the rare occasions that they are added, they are, just like this example with cancer and COVID, belated afterthoughts for which scientists, often nurse scientists, have to fight tooth and nail to have these as recognized social aims, clinical aims, or research aims of importance. So our own National Cancer Institute, for which we are extremely grateful for the funds they put in to cancer clinical trials, still misses the mark in a tremendous way by not routinely including the social determinants of health in all of our studies. And that is almost never discussed.
So many things are changing in our world, and people have said we are not going back to, where things were before. And I think this is an excellent example of, as all of this change is happening, making sure that that is heard at those levels so that social determinants of health can be included in all of those studies. I can see your passion with that, as well as just the importance of having that in there to add another layer of why we have the outcomes that we do have and what we can do to improve those outcomes and how we can improve things for those patients, as well as getting the resources into the hands of healthcare providers and nurses that are working with these patient populations day in and day out. What are some of the resources related to social determinants for both oncology nurses and patients that, as nurses who are listening to this podcast and seeing this in their practice can start utilizing so that they can try to advocate for their patients and starting to make change?
There are resources. It does take work to collate them, to have them at hand, to be sure that we're connecting patients. Different clinical sites have different resources, unfortunately. And sadly, some of the clinical sites in those environments with the worst social determinants of health have less access to what is needed. So understanding what the state provides, what the clinical site provides, what the federal government provides is critical. Having social work or navigators, nurse navigators, that can help people navigate the system that gives them access to care, access to medications, working on health literacy to help people understand the importance of advocating for themselves or getting the medications, getting the help they need with insurance, transportation, diet, and exercise. There are resources, but again, they're limited and need to be at hand. I think the most important thing is that oncology nurses need to have some page handout full of names and phone numbers at their ready to help refer people to what is needed.
Thank you. Those are really good resources and at least a direction for nurses to start working in. I know in thinking about this, as healthcare providers, when we have family members that end up with a cancer diagnosis or some other type of diagnosis, and because we know the system, we advocate hard for our family members to get to the best doctors or the best hospital or get on clinical trials for the best outcomes that could happen. And when we're looking at this population and patients that do fall within this population, and as you said before, having the ability and the confidence to advocate for themselves would be extremely difficult. And I can see where this is such an important piece that all oncology nurses need to start recognizing in a stronger way and advocating for those patients. Is there anything that you would like to add at this point about social determinants?
2 final points. One is oncology nursing is still primarily a profession of women, certainly not exclusively anymore, and a growing number of men are in the cadre. But if we can remember back to prior to 1993, before the NIH mandated that clinical trials had to include women, I think women were fairly outraged at the fact that, well, all clinical trials, cardiac, et cetera, but particularly cancer clinical trials, accrued mostly men. And we were beginning to learn that there were different outcomes for women and that we needed to understand them. And so the NIH mandated the inclusion. As women, we wouldn't stand for the exclusion of women now in healthcare or research. We should not stand for the exclusion of social determinants of health, just the way that we have learned that women present differently with cardiac disease. We know that people who have poorer social determinants of health present differently and have different outcomes. So we need to be as enraged as if they were saying that we shouldn't assess gender or even include women in research and clinical practice, which is the state of the art right now, the poor state of the art, when we don't include social determinants of health, or we don't go out of our way to accrue patients who have poor determinants of health in research. We should be outraged. I fear that in today's environment, there is so much to be outraged about, so much to be concerned about, whether it's COVID or the economic impact of COVID, the downturn in economics, whether it's violence, whether it's social injustice, whether it's the targeting of African Americans by police units, whether it's the incivility of our leadership. There's just so much stress out there today that while we say that this is really a new era and we're not going to let this stand and we're really going to attend to the social determinants of health, which is tied up in most of the things I just mentioned, I fear that we will go on to the next concern, outrage tomorrow and leave this behind. I hope I'm wrong. I would love if there was some way that oncology nurses could really not drop this ball and lead in a consistent pursuit of assessing, addressing, and advocating for the social determinants of health.
Thank you, Deborah. I think you have given us all a lot to think about. And as we pride ourselves in advocating and giving the best care to our patients and hoping to improve the outcomes of treatment and, through that care, that we will take the time to, as you say, start making strides and making this a priority and not just something that is on the wind and that we won't forget about that because it does have a huge impact on patient outcomes. I just would like to thank you for joining us today. And we look forward to hearing the session that you're part of for the 2020 ONS Bridge virtual conference.
Thank you, Stephanie.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you download your podcasts. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org.